Assalamu alaikum, everyone. I hope you're doing well. My name is Samra Mirza, and I'm a fourth-year medical student. Today, I'll be with you for the deep cerebral structures. This includes a series of 4 lectures: the basal ganglia, the thalamus and internal capsule, the cerebellum, and lastly, the limbic system. Before I begin, I just want to say Ramadan Mubarak to all of you. I hope your month has been going well. It's the last 10 nights and days, I guess, based on when you're watching this. And I'm just praying that may Allah add barakah to all your efforts and all your ibadah, and may Allah accept all your studies as ibadah. May Allah continue to bless this month and the ones after this for you guys. If you have any questions, feel free to contact me through my phone number or through my email, whatever you're comfortable with. And yeah, without further ado, we can begin. As I mentioned, these are the lectures I'll be covering, and I have changed up the order a bit from their original teaching order, but that's just for ease, inshallah, and it will be beneficial to you guys. And yeah, take a look at that vision and mission statement, and yeah, inshallah, you guys will be doing the same next year. So once we begin with basal ganglia, I want to let you guys know that the essential purpose of basal ganglia is to really clean up movement, to make sure that there's refinement in the actions that are being carried out, specifically when there's complex motor movements being carried out, and especially when there's movements of dexterity, for example. So the basal ganglia is essentially a bunch of nuclei. They're subcortical and they're involved in voluntary motor control. So let's say lifting up your left arm, it's to make sure that you're not lifting it up way too much, and it's not too low either for it to not be considered, say, lifting your arm. So really the amplitude of your motion, the degree of how much you're moving it, it really helps refine those movements. So a lot of functions of the basal ganglia that can be outlined are initiation of voluntary movement, suppression of unwanted movements. So let's say you're raising your left arm, you don't want to be raising your left leg alongside it. Obviously, that's a bit theatrical, but to help you understand what it could mean. And lastly, regulation of muscle tone. So when you're at rest and you're not moving, to ensure that your muscles are in a unified tone, they're all, one's not extra contracted or relaxed, if that makes sense. And yeah, and the way the basal ganglia coordinate all of this is through a lot of feedback loops, a lot of communication consistently between the cortex, the thalamus, basal ganglia, and even the cerebellum at times. So there are 5 nuclei in the basal ganglia, and there's a bunch of groupings for them, but we'll go about the anatomical way first. So the first nucleus you have is a caudate nucleus, then you have the putamen, then you have the subthalamic nucleus, then you have the globus pallidus, both interna and externa, and then you have the substantia nigra with its parts pars compacta and pars reticulata. So that's the 5 nuclei that you have. Another way to look at it is when you start grouping them based on certain functions. So the whole purpose of the basal ganglia is to really explain the basal ganglia circuitry, right? And every circuit has an input and output. So the main input that you would have for the basal ganglia is something called the striatum. Now the striatum is a collective term. It's used to refer to the caudate nucleus and the putamen. So here, and additionally, nucleus accumbens. As for the major output of the basal ganglia circuitry, you have 2, globus pallidus and substantia nigra, and it's 2 parts. So you have 1 and 2 essentially, input and output. Another way to also refer to some part of the basal ganglia, another set of terminology that you're supposed to know, is something called the lentiform nucleus, which essentially encompasses the putamen and the globus pallidus. So here and here. These are a bunch of terminologies, but we'll go into an image, inshallah, and it'll help clarify it for you. So whenever I begin with this image, I always find it easiest to start from the ventricles. So here, we're going up the 3rd ventricle, and then obviously to the lateral. And right under the lateral ventricles, you'll always find your caudate nucleus. So that's the easiest thing to always identify from the get-go. Right next to the 3rd ventricle, on either side of it, you have the thalamus. And it's good to just get it out of the way. It's not part of the basal ganglia, it's just in communication with it. And then you have this little pizza-shaped structure for those of you who are fasting today. Cooked, right? But yeah, this is the putamen right over here on the lateral side of it. And on the medial side, you have the globus pallidus. Externa here and then interna here, if that makes sense. You would also have the subthalamic nucleus and the substantia nigra on top of each other near the bottom, but it's not going to be visible in this cut section. And then once again, there's another diagram for you to refer to here. This is just to show you which structure is most medial and then which is most lateral. So again, the thalamus, pallidus interna, pallidus externa, putamen, and then the caudate nucleus, which you can appreciate as a C-shaped structure and not just like a little round blob. And here's another set of image for you. This is from your lectures directly. And again, here you can just appreciate against the caudate nucleus, the putamen, the globus pallidus, again, the lentiform nucleus as they're referred to collectively. And you also have the internal capsule highlighted here. This is a really good image for it. And inshallah, we'll come back to those as well, so no need to worry about it just yet. So back to the circuit that we were talking about. We mentioned input and we mentioned output. Now we need like little channels of communication inside the circuit. So you have something called excitatory neurotransmitters and then something called inhibitory neurotransmitters. The name gives away what they are, obviously. Let's just know the examples. A major one for excitatory is glutamate. Then a second one is D1 from dopamine, which is in the substantia nigra. It's a rule of thumb to remember substantia nigra is obviously the main releasing point of dopamine. So when you have substantia nigra in your circuit, it's going to give it out at one point. D1 being the excitatory neurotransmitter, D2 being the inhibitory one. Another excitatory transmitter we have is acetylcholine. And lastly, another major inhibitory neurotransmitter is GABA, of course. So major ones we have are glutamate and GABA. And then supporting ones include D1 and D2 and acetylcholine. So as we mentioned, the basal ganglia is essentially making sure that there's regulation in your muscle tone at rest, right? So it does this through something called the tonic inhibition of the thalamus. And the thalamus is essentially tonically inhibited by the globus pallidus interna and the pars reticulata. And this makes sure there's no unnecessary movement that's occurring when it's not supposed to. Now, what does that mean? Essentially, if you look at the little dotted lines, the dotted lines are supposed to represent action that wants to be carried out but is not being carried out, right? And the reason is the thalamus wants to stimulate the cortex and the spinal cord and brainstem. Therefore, it wants to stimulate a movement and wants to give those signals. But when you're at rest, you don't need those signals and you don't need any movement to occur. So how is this prevented, you would say? The globus pallidus interna would release glutamate, as you mentioned, because that's the inhibitory neurotransmitter that we have. It would release glutamate and it would inhibit thalamus, thereby preventing any signals from going to the cortex and spinal cord that would initiate movement. The pars reticulata would obviously support this and again also help inhibit thalamus. That's pretty much it that you need to know for what's occurring at rest. And now that you know what's occurring at rest, you can imagine that what needs to be done to activate it. So the basal ganglia is essentially an inhibitory circuit in its essence, and the start at rest even. And so now when you want to activate something, what would you have to do? You would have to remove the inhibition. With that, we come into the activation of the basal ganglia circuit. Now, there's something called the direct pathway, which is involved for activation, and then there's an indirect pathway that's involved for inhibition. Starting off with the direct pathway, you want to initiate a movement, you want to cause some sort of contraction or something like that. And how do you go about it? The cortex would send signals to the striatum. Striatum is again encompassing the caudate nucleus and the putamen and the nucleus accumbens. And it's once excited by the cortex, it's now going to release signals. This is a major input that we had, right? It's going to release signals. What's it going to do? It's going to go to the globus pallidus internus, which was actively inhibiting the thalamus, and it's going to stop that inhibition that it was doing. So now, once the globus pallidus internus is stopped, it can no longer stop the thalamus. So now the thalamus is uninhibited, and it can go back to what it wanted to do, which was stimulate the motor cortex and therefore the spinal cord for movement. So let's put this in a diagram. we want movement, so the cortex is going to send it to the striatum. We recall that the neurotransmitter responsible for excitation is glutamate, so it's going to send glutamate to the striatum, activating it. The striatum is then going to inhibit the globus pallidus interna, and it's going to do that through GABA because that's the inhibitory transmitter that we have. Globus pallidus interna now inhibited. Obviously, you can see that its line is dotted, so it can no longer affect the thalamus, and the thalamus is very happily carrying out its actions. Other supporting actions that are being carried out through this is that the cortex is also going to stimulate the substantia nigra pars compacta, again through glutamate. And now the pars compacta is going to release D1, which is another excitatory neurotransmitter, to just further reinstate the action of the striatum, to add more to it, make it more potent, if you will. With further support from the pars compacta, striatum doubles down on this, makes sure that the movement's occurring. It even inhibits the pars reticulata and prevents any inhibition from going on that side either. So just to recap, what are we essentially doing? We're removing the inhibition that the thalamus had by inhibiting the inhibitor. And this is what is done for activation in the basal ganglia. Now let's talk about inhibition. Now for inhibition, you want to essentially stop a movement. So you're at rest, and at rest, you're already in an inhibited state. Now you want to double down on that, right? So what you're trying to do is, end goal is you want to make the thalamus more inhibited than before. So how does this go? How do you go about this? The cortex excites the striatum once again, and now the striatum is going to inhibit the globus pallidus externa. Keep care of that part. You don't want to confuse this with the interna. Here, the striatum is inhibiting the globus pallidus externa. And the reason it's doing it is because the globus pallidus externa had an inhibitory action on the subthalamic nucleus. So it was also tonically inhibiting the subthalamic nucleus. Now, what was the subthalamic nucleus and what was it doing? During all of this, the subthalamic nucleus on the side activates the globus pallidus interna and helps it support in its inhibition of the thalamus. So when the globus pallidus externa is inhibiting the subthalamic nucleus, it can no longer support the globus pallidus interna and support the inhibition of the thalamus. So what are we doing? We're removing whatever inhibition there was on the globus pallidus externa, the subthalamic nucleus by the globus pallidus externa, and therefore allowing the globus pallidus interna to, again, double down on its inhibition of the thalamus. It can sound a bit confusing when we look at it like this. Let's go to a diagram once again. Starting from start, the cortex, that's a dumb statement, but yes, the cortex stimulates striatum through glutamate. Now, the striatum is going to do this. It's going to inhibit through GABA the globus pallidus externa. So now that the action the globus pallidus externa wanted to carry out, which is the dotted line, was inhibition of the subthalamic nucleus, which it can no longer do. So now the subthalamic nucleus is very happily going to go, and it's going to go and it's going to stimulate the globus pallidus interna. It's going to do that through glutamate. And now the globus pallidus interna is more activated than before. The globus pallidus interna is then therefore going to go and really very intensely inhibit the thalamus and therefore the cortex and spinal cord, and there's no movement occurring. I hope that makes sense. Essentially, in order to activate the globus pallidus interna, you need to inactivate or inhibit the globus pallidus externa, which would allow subthalamic nucleus to be activated and support the globus pallidus interna. With that part done, let's talk about what else is going on. The cortex is also going to send signals to the pars compacta, stimulating it through glutamate. And this time, the pars compacta is going to release something called D2, which is an inhibitory one. Now you'd say, why are we trying to inhibit the striatum when it's doing all this? And things can get a bit confusing. But as I mentioned in the start, D1 and D2 and acetylcholine, these are mostly like modifiers. They're not controlling the whole circuit, they're just supporting it here and there. So the D2, what you need to know in this cycle, that the D2 is just, again, a modifier, refiner of this inhibitory cycle. And it's just making sure that there's not any overacting or underacting on the part. So here, in this sense, making sure there's no overacting at the striatum. Just know it as modifiers of this cycle. So the modifier for the direct pathway is D1, and then modifier for indirect pathway is D2. So once again, I'm just going to do a quick recap for you. At rest, the thalamus is inhibited tonically by the globus pallidus interna and the pars reticulata. This means there's no movement occurring. Upon activation, the striatum is excited by the cortex, and then the striatum inhibits directly the globus pallidus interna and the pars reticulata, preventing any inhibition of the thalamus, allowing signals to be carried through the cortex and spinal cord, which support movement. In this process, the D1 neurotransmitter is just supporting the striatum, while the main acting neurotransmitters are obviously glutamate and GABA, respectively. As for inhibition, you use something called an indirect pathway, and if you look at it, it really is a bit indirect, right? You want to really increase the inhibition on the thalamus, and that's already going on at rest by the globus pallidus interna, but you want to double down on it. So you're going to do something which can support the globus pallidus interna, which would be the subthalamic nucleus. In order to activate the subthalamic nucleus, you would remove its inhibition that's done by the globus pallidus externa, and now the globus pallidus interna is acting even better than before alongside the pars reticulata, and together they're bringing the thalamus to a stop, its actions to a stop, and then the cortex and spinal cord, so there's no movement occurring. Supporting modifiers in this case are the D2 neurotransmitters, and of course, glutamate and GABA are working in their respective roles. Obviously, there's glutamate involved here, where there's excitation, and GABA when there's inhibition. Well, that we're essentially covering completely what the two circuits are. I know the diagram is a bit different from the ones in your lecture. I hope it still makes sense, and I hope it's clear so far. Now we're just going to talk about some disorders that you have. So as we mentioned, the basal ganglia is working to really refine your movements, make sure unnecessary actions are not occurring when you're doing a specific action. It's helping you carry out some of your more complex actions, especially those involving dexterity, right? So when there's disorders occurring in this place, you can imagine that there might be too much movement on one part or too little movement on another part. So that's what this is. So Parkinson's is one example of a basal ganglia disorder. Parkinson's targets the substantia nigra, as we know, and that means there's degeneration of the dopaminergic neuron, so there's less dopamine overall in your system. This causes something which is known as a hypokinetic disorder, so there's less movement, right? And that's what makes sense. This is essentially, we remember what's the role of D1 and D2 in dopamine in general. The role of D1 in the activation and the direct pathway was to essentially really double down on the striatum and help it make sure that it's, acting to the right amount and make sure that the degree of its stimulation is well and supporting it and essentially inhibiting the globus pallidus interna. Now, with the dopamine not being there, the striatum is working on its own through glutamate, and there's no backing support from the D1, and this can lead to the thalamus still being inhibited in a state when it shouldn't be. So this can lead to, so what do we have right now? We have some movement, but we also have actions inhibiting that movement. So this is causing hypokinetic disorder. So the inhibition is still kind of trying to override the activation. So what are the features of Parkinson's that you'd notice? You'd notice bradykinesia, which is slow movement. You'd notice a resting tremor, which is a very classic sign for Parkinson's. You'd notice rigidity, a mask-like face, a shuffling gait. And it's always good to look at pictures of this, and I do recommend that for you guys, just to help, just to like orient yourself, essentially. Again, the location of this is the substantia nigra pars compacta, which was essentially releasing these neurotransmitters in the first place. So that's right here. And then another disorder we have is Huntington's. Contrary to Parkinson's, Huntington's is a hyperkinetic disorder, so there's too much movement going on. Essentially, Huntington's is caused by degeneration of the striatum, particularly the caudate nucleus. That's all that you need to know for this. Another thing you need to know are the features that Huntington's presented with, and it's coming with chorea, it's coming with psychiatric disturbances, and it's coming with cognitive decline. So it's having both emotional changes as well as movement changes. Now, the difference between Parkinson's and Huntington's, there's a bunch, obviously. A nice way to differentiate it is obviously how the disease is inherited. Part of Huntington's can be partially hereditary, and it's usually as it goes down the family line, it's starting earlier in every individual. So let's say a father had it in his 40s, their child can have it in their 30s, and so on. Huntington's usually starts with mood changes first, psychiatric disturbances start first, and then the movement disorders come later. While for Parkinson's, you have the movement disorders coming first, and then the mood changes coming on as the disease progresses. There's a little image for you to help you identify. Obviously, you can see that there's shortening of the caudate nucleus on the Huntington side as there's degeneration occurring, right? And Parkinson's, you can notice that the substantia nigra, which quite literally means the black substance as it's supposed to show on the imaging, it's decreasing, it's not of the same strength. And then the last disorder you need to know is hemiballismus. Hemiballismus is caused by a lesion on the subthalamic nucleus. The lesion could quite literally be a stroke, for example. So with this lesion, now you would have, let's recall what the subthalamus was doing, right? The subthalamus ideally wants to support the globus pallidus interna in its inhibition of the thalamus. So if the subthalamus is now degenerated, you do not have that activation of the globus pallidus interna, and therefore the inhibition of the thalamus is decreased. Or it's not to the strength that you need it to be when you're doing an inactivation of it. So what are the features of it? You have an inhibition that's not occurring the way it needs to. There's going to be a lot of excessive movements. So in this case, you would have violent flinging movements of the limbs, and you'll notice it in the pictures that are in your lectures, or you can search up a video for it as well. I couldn't submit one in the slides that would be sufficient to explain it, but it's always good to search these things up. And so, just to wrap up, Parkinson's affects the pars compacta of the substantia nigra. Huntington's affects the striatum, specifically the caudate nucleus, and hemiballismus affects the subthalamic nucleus. With that, we come to the next part of the basal ganglia, which is the blood supply of it. This is obviously very important to know because you want to know what a stroke would do, essentially, to a lot of these areas. So the first arteries that you have are the medial striate arteries. They're also known as the recurrent artery of Ubner, which is a branch of it. And these are branches that are initially coming from the anterior cerebral artery. So MSA, if you will, coming from the ACA, and it supplies the medial side of the basal ganglia. So if we recall the little diagram that we had in the start, the little pizza. I'm not the best at drawing sometimes. The pizza that you have, the putamen and the globus pallidus, and then later the caudate, more internally or medially the thalamus. So these are the structures you have. So the more medial side of them are being supplied by the MSA. And essentially in this side, because these arteries are narrow enough and so on, there can be an easy aneurysm that can occur specifically in a patient profile where there's hypertension involved and whatnot, long running. Then you have lenticulostriate arteries. Lenticulostriate arteries come from the MCA, so the middle cerebral artery. So we're moving one step forward now, and they supply the lentiform nucleus area. The lentiform nucleus is very obviously the whole pizza that we refer to, the putamen and the globus pallidus. This is a major site for stroke. Small arteries, they can easily get blocked. There can easily be a lacunar stroke and a hemorrhagic stroke that occurs again in hypertension. Then you have the thalamostriate arteries, and these come from the PCA, and they also supply portions of the basal ganglia here and there. And this little diagram just summarizes what you might have as main things. So we mentioned the putamen, which is again from the little pizza. It's supplied by the lenticulostriate arteries majorly, and it can have a lacunar stroke. We have the globus pallidus, which is supplied by a bunch of arteries. It's supplied by the MCA, CA, PCA. There are branches, essentially these ones, the MSA, the LSA, the TSA, I guess we can call it, those arteries. Defects here would lead to motor defects, which would essentially be a result of any basal ganglia injury. The caudate head, that being damaged could cause behavioral changes, as we've noticed in the Huntington's disorder, which causes major behavioral changes to occur. Subthalamic nucleus, as we remember, causes hemiballismus, and then internal capsule causing motor stroke. We'll get into that, inshallah. With that, we are done with the basal ganglia. I hope so far so good. I hope we're clear. And now we'll come into the thalamus and the internal capsule. The thalamus and the internal capsule, just like the basal ganglia, are working to really modify movements. The thalamus, mostly. It acts like a little gateway. It's filtering everything that's coming to the cerebral cortex. So here, as we remember the little diagram, the thalamus is on either side of the third ventricle. And as you mentioned, it acts like a relay, a filter, and it processes everything that's coming in, the motor, the sensory. It's like a security guard sitting at the cerebral cortex, and it's just monitoring everything that's coming in and going. It helps integrate the signals, so it checks what's coming in, allows it to pass through, and so on, make sure it's going in the right direction, the right lobe, and so on. It also participates in consciousness and alertness. Now, just to get it out from the start, all sensory pathways follow through the thalamus before reaching the cortex, except olfaction. Olfaction very easily bypasses it to go to the thalamus directly through another route, to go through the cortex through another route, sorry. So everything except olfaction. Let's just get it out of the way. The thalamus is not involved in olfaction. So the components of the thalamus that we need to refer to, there's going to be the thalamus, the hypothalamus, epithalamus, subthalamus, and also the metathalamus. Now, the hypothalamus has been learned in ERP multiple times. We know its functions in regulating the pituitary hormones, GnRH, DHRH, TRH, and so on. Also, hormones like ADH, oxytocin, and so on. So we know what the hypothalamus does. It's a lot of endocrine functions. So we'll go into the thalamus, epithalamus, metathalamus, and subthalamus. And before we do that, let's have a little teeny tiny embryology recap. You have the prosencephalon, the mesencephalon, the rhombencephalon. From the prosencephalon, at the top, you have telencephalon, which gives you the cerebral hemispheres, and diencephalon, which gives you the thalamus and the third ventricle. Now, you need to remember, essentially, the ventricles and the cavities and the walls associated with each cephalon. So, very easy for us in this case, in my opinion, to remember the thalamus is associated with the third ventricle as per the diagram we've seen. Another way I like to remember it is by, the D in diencephalon, the D in third ventricle. Something to help you remember it by. If this makes it more confusing for you, don't stick to it, for sure. So that's the main thing we're focusing on. Obviously, there's more in the mesencephalon and the rhombencephalon and their relative cavities, but our focus is the thalamus, so we're just gonna go with this. So here's a little diagram just to show some anatomy of it. We're looking at it from the side, and here we can appreciate the thalamus, and right below it, obviously, the hypothalamus, and as the name suggests, but under that, even the subthalamus, and then the epithalamus, which is on the other side of the thalamus in general. This is another diagram to really show what the structure and the divisions, specifically the functional divisions of the thalamus look like, as well as the anatomical divisions, and you should definitely take a closer look at it. So let's look at the thalamus. Um, the thalamus. I'm sorry, guys. It's Ramadan and everything starts looking like like a little piece of meat, honestly, when you're hungry. So this is just a diagram to help you remember the thalamus by, hopefully, from this very Tom and Jerry-esque cut of meat. But let's not get distracted and let's get back to the thalamus. The thalamus has major groups, so let's see what the groups are. The groups are the anterior side, the dorsal side, or the lateral side, sorry, if you will, which is all the way over here, and then the medial side. So there's three main sides: the anterior side, the lateral side, and then the medial side. It can sound confusing, and I have it organized again for you over here: anterior, medial, and lateral. Three main sides, separated, one over here, two over here, and then three just lo and behold, that big side here. So let's just learn the names of these for now, and we'll get into the functions of them one by one. Anterior side obviously has the anterior nucleus. Medial side has something called the mediodorsal nucleus based on its positioning. And then the lateral side has the most divisions. It has the VA, the VL, the VPL, and then the VPM. And then you have more medially, you'll have the medial geniculate, the lateral posterior, and it's okay. There's a lot, but we'll get into it. But before we do, something that I need you to remember for the thalamus is its communicating point. And the way you need to remember this is is through histology because that's where it's mentioned. We know that there's 6 layers of essentially cells, right, in the nervous system. And so the layer that's responsible for communication to the thalamus, it's one direct channel, and it's the 4th layer, the internal granular layer, and it's like solely for the thalamus. And so you need to remember that layer number 4, internal granular, is in charge with communication for the thalamus. Coming back into the main groups that we had, I want you to know that the internal and medial group are both parts of the limbic system and not really supporting the thalamic functions other than this that much. So obviously we have the limbic system in much more detail later on in this lecture, but just to cover part of it right now, the limbic system really deals with a lot of your memory, your emotions, your cognitive states, and so on. So part of the limbic system, there's something called the Papez circuit. And this Papez circuit essentially involves the anterior nuclei, as we mentioned, and it's working when the thalamic gate is closed, which is a big thing. The thalamic gate, so the thalamus is a gateway, right? And it's really filtering every information that's coming in. When you're sleeping, there's really not much going on. Like, think about it. When you're sleeping, other senses around you are not really that noticeable to you, except smell, which is something again that doesn't pass through the thalamus. And so it closes the thalamic gate, and this is what allows memory consolidation to occur on the side. That's why when you're sleeping, it helps build whatever you're learning. Therefore, try not to be sleep deprived this Ramadan. So again, Papez circuit works for memory consolidation using the anterior nuclei as part of it. This is just the little formation that you need to know of how the circuit goes about. It's always good to know these because the doctor could ask what's the relevant part, what's communicating with the what and where. So, like, to put it simply, it starts from the hippocampus. In the hippocampus, you move on into the fornix over here. And then as you're following the track through the mammillary bodies, you end up entering or synapsing with the interior nuclei of the thalamus. And once you do that, the thalamus will now pass this, um, I guess, signal forward, passing it forward to the cingulate gyrus of the 4th lobe. And you can see it doing that over here right now. And then later on to the frontal lobe, as we mentioned, for consolidation and so on. And also down here to the hippocampus and the hippocampus cortex, which is a very important part of the limbic system. And we'll get into it, inshallah. Just remember hippocampus, fornix, mammillary body, anterior nuclei, cingulate gyrus, front lobe. And yeah, this runs very close to the 3rd ventricle. So as the thalamus in general runs very close to the 3rd ventricle, just remember that the Papez circuit is running close to it. Another thing to note is damage here, but obviously lead to amnesia because this is what's working for memory consolidation. So remember it by AN for anterior nuclei and AN for amnesia if you need to. And yeah, so that's anterior nucleus done. Then we have the medial. The medial has a dorsomedial nucleus. This is again part of the limbic system, but now we're working with something else. We're working with something called the amygdala, which is really responsible for all your emotional states, particularly fear. And the dorsomedial nucleus is very important in this. Again, the pathway that you need to know for this is you have the amygdala, and from the amygdala, we're going into the prefrontal cortex and the temporal lobe. Then from there, we're going into the dorsomedial nucleus, and then from there, prefrontal cortex and cingulate gyrus, which is really the receiving end for all of these, especially the hippocampus formation in between. So essentially, anterior nucleus is working in the Papez circuit. It's working for memory consolidation. It's in communication with the mammillary bodies, and it's also in communication with the cingulate gyrus. As for the dorsomedial nucleus, it's working alongside the amygdala for the processing of fear and so on. And it's really working with the amygdala through the temporal lobe, like the channels there, and then down again to the cingulate gyrus. With that, we covered the 2 limbic system parts, and now we have to cover the literal lateral parts over here, right? They're not too much, and they're actually pretty simple. So there's a bunch of divisions of the lateral part. Obviously, there's the ventral side, and then there's the dorsal side. The dorsal side, although yes, exists, it's not of too much significance functionally. It's not well known, but the ventral side is very well known. You have the ventral anterior side, the ventral lateral side, and then the ventral posterior side, based on the positioning of the thalamus alongside in your normal human body. In the ventral posterior side, you'll have the VPL and the VPM, which is again just lateral and medial inside the posterior part. Another thing to note for the dorsal side, you have the lateral dorsal, the lateral posterior, and then the little pulvinar, which is also a term for pillow, as mentioned in your lectures. It's like the thalamus is sitting on a pillow. So to come into their functions, the ventral anterior, ventral lateral, and ventral posterior. As we mentioned, the thalamus is a gateway. It's taking in everything that's coming, going through it, like really skimming through everything, making sure everything's correct, and then sending it and making sure it's going to the right areas. So ventral anterior is responsible for motor. So everything that's related to your motor signals is coming in. And then where is it coming in from? It's coming in from the basal ganglia. If we recall, the thalamus is what's getting inputs from the basal ganglia, right? The thalamus is getting inhibited by the globus pallidus interna, or it's getting activated through the striatum. So really and then this basal ganglia is what's allowing the thalamus to then send on signals to the cerebrum and the spinal cord. So it's in communication with the basal ganglia. So it's getting input from it. So the ventral anterior part of the thalamus receives input from basal ganglia, and then it filters through it, and then it sends it forward to Brodmann areas 4 and 6, which are actually your motor cortex, your primary, and your pre. We remember that the globus pallidus interna was in contact with the ventral anterior part of the thalamus at this point. Then we have the ventral lateral side. The ventral anterior is doing motor control, specifically in reference with the basal ganglia. Then we have the ventral lateral, which is again doing motor control, but this time in communication with the cerebellum through something called the dentate nucleus, and we'll get into it. But essentially, it's again getting input from these structures, and it's filtering through them, looking through them, vetting them really, and then sending them to the right areas. So to again Brodmann areas 4 and 6, which are responsible for movement. So VA and VL are both for movement, and now we come into ventral posterior. So that gives you VPL and VPM. These are mostly just taking in senses from all over the body on the contralateral side. Remember this, very, very important for the thalamus. So the VPL, look at the letter L and look at the letter limbs and, correlated through that. VPL is for senses from the contralateral limbs, arms, legs, and so on. It receives those, vets through them, sends them to their respective areas, Brodmann areas 3, 1, 2, which are part of your somatosensory cortex. Then you have VPM. VPM has an M here and M essentially think of mug. You can think of a mug shot, which is of the face, or you can think of a mug where people drink and you drink, you bring it to your face. Whatever helps you remember that VPM is for the face. So VPL was for the limbs and VPM is for the face. Again, sending them to the respective areas of Brodmann areas 3, 1, 2, and also Brodmann area 43, which is for taste. And that is also going to the insula. Now, for VPM, it's receiving this information through the tract of the trigeminal thalamic tract, which is just good to know. So again, ventral anterior is for basal ganglia communications for motor control. Ventral lateral is for cerebellar communications, again for motor control. VA gets it through globus pallidus, VL gets it through dentate nucleus, and the VPL and VPM are for sensory changes and for sensory information to then send on to the right areas. Trigeminal thalamic tract for the VPM, and for the limbs, it's just the normal tract that you have coming on, the spinal ones. And then this is just a little recap for the basal ganglia once again, just to add that here you would be involving the basal ganglia with the VA and the VL part of the thalamus, both parts of those circuits, because they are interlinked. Something I wanted to, sorry, before I forget, something I wanted to bring to your attention for the thalamus when we're looking at it is that, or let me come here even to help explain this better. To our little meat, you see that the lobes of it are formed due to this part running in between the meat, really, right? It's like a Y-shaped structure, and it's essentially the fatty part of it, right? And that's what is in this case too. This is something that's called the internal medullary lamina, the IML. The IML is formed from white matter, which is essentially the more fatty matter, and it's causing the separation in the lobes here. There's also something called the external medullary lamina, but it's mostly a covering and it's more medial or more laterally covering of the thalamus in general. Ooh. 1 second. technical difficulties. And okay, back to it. With that, we covered the VA, the VL, the VPL, VPM. Now to move on to the metathalamus, the LGB and the MGB, the little bodies that we saw sitting over here and here. Sorry, here. So the lateral geniculate body processes light. So L for light. I hope this doesn't confuse you with the ones we discussed previously. But the lateral geniculate body is used to process light. And when you think about processing light, you can understand that this is for vision. This is just visual connections. You have cranial nerve 2, the optic chiasm, the cussations, and then the tract, then the LGB, and then Brodmann area 17. A lesion here would lead to contralateral homonymous hemianopia without macular sparing. Good to know. An LGB hit would essentially cause contralateral homonymous hemianopia without macular sparing. Just remember that, and remember the little diagram that you have to show what macular sparing looks like, or without macular sparing, which would be essentially the circles in between that are showing damage. Then you have the medial geniculate body. The medial geniculate body processes music. So essentially L, light, M, music. This is just to help you remember that the medial geniculate body is for sound. So you have cranial nerve 8 sending things through the superior olivary nucleus and the inferior colliculus, overall leading to the medial geniculate body, which then forwards it to the Brodmann areas 41 and 42. So it's really, again, it's like a traffic police even, getting everything and sending it in the right direction, as we've already discussed. And a lesion here would lead to bilateral partial hearing loss. Because, and it's partial because this is not the entire, it's not entirely controlling the auditory part of your brain, right? It's just filtering and sending things through. And damage here would not lead to complete loss, rather just partial loss, less refinement, and so on. This is a little table. It's from the Boards and Beyond lectures, which are very nice for the on the entire neural block, really. And this is just to again summarize what they do. VPL is everything sensory, pain, temperature, touch, proprioception, vibration. These are the tracks mentioned. VPM is for face and taste. That's a nice way to remember it. And these are, again, important to note, the trigeminal and the gustatory tracts. LGN or LGB is vision, MGN or MGB is hearing, and VL is motor, and also VA. Then we come into the blood supply of the thalamus. The thalamus is supplied by the PCA, the posterior communicating artery, the artery of Percheron, which is important for paramedian thalamic infarction, and then the thalamoperforating arteries, which is important for thalamic pain syndrome. Now, what you need to note for both of these is the following. What you need to know for the paramedian thalamic infarction is this is caused by a block at the artery of Percheron or at the very top of the basilar artery. This is a very severe stroke. It can lead to a comatose state, a very long state, and it has a poor prognosis because it is affecting your memory consolidation areas as well. Because as we remember, the anterior nucleus and the dorsal medial nucleus are parts of the limbic system. The anterior nucleus, particularly part of the Pappas circuit. So damage to the thalamus in this sense through the artery of Percheron through the top of basilar artery stroke can lead to comatose state, poor prognosis, even memory loss in cases where they are awake. Then we talk about the thalamic pain syndrome, which is through the thalamoperforating arteries. This essentially is when there's loss of overall senses on one side of the body. It's on the contralateral side, as you remember, because that is how it goes for the thalamus. They can also have central pain if certain areas are involved, and it can lead to a lot of aching, burning, and that's why it can be referred to as thalamic pain syndrome. It's usually not treated well by analgesics, and yeah, these are little images for you to note what each syndrome looks like, what each disease looks like. It's always important to know it for your OSPs and even for your MCQs. You never know how the doctors want to ask it from you. And yeah, moving on, we'll now cover the internal capsule. The internal capsule really is this, right? It's this V-shaped structure that you're seeing here. And the importance of the internal capsule in all of what's going on right now is that all the fibers that you're getting, the dorsal column tract, the corticospinal tract, the cortical bulbar tract, all these tracts that are coming in, they're passing through the internal capsule. And if you notice, the internal capsule is a bit narrow. So when these tracts are together, they're very close by. They're all like in complete association and they're very close. Like you can have them passing almost right next to each other. And at some points, they're more in contact than others, and so on. Now, the reason this is important is because damage to any part of the internal capsule, which is this area, can lead to a multitude of things, right? It's more severe on that end. And we'll get into that. So, talking about about the internal capsule in relation to all of its surrounding structures, it's surrounded by the caudate nucleus, it's surrounded by the lentiform nucleus. You notice them right here, and it's surrounded by the thalamus, which is right here. So, moving on to the parts of the internal capsule, we have the interior limb here and here. You have the genu, which is the little curvature, and then you have the posterior limb. The anterior limb is between the caudate nucleus and the lentiform nucleus. This is the one that contains frontopontine fibers and thalamocortical pointers. Thalamocortical fibers, sorry. The genu contains the corticobulbar fibers, very important to note. And the posterior limb is between the thalamus and lentiform nucleus, and it contains the corticospinal tract, somatosensory tract, optic radiation tract, which is lentiform, and then the auditory radiation tract, which is retrolentiform. Good to know these names, obviously, and where each is coming from. Optic is sublentiform, auditory is retrolentiform, and this is just referring to how their movement goes in relation to the lentiform nucleus. Then, moving on to the blood supply of the internal capsule, because as we mentioned, it's lesions here that will lead to devastating outcomes. So you need to know what these lesions could be. They could be for the lenticulostriate artery, which is common for lacunar strokes, or the anterior choroidal artery. Any vasculature of the internal capsule is of utmost importance because it's such a consolidated area that even the tiniest bit of damage can really lead to long-term and vast long-term side effects. So we'll be talking about it now. The posterior limb. Let's see, the posterior limb has all these tracts running alongside it. So damage here can lead to contralateral hemiplegia. Now you know that for cerebral strokes that are occurring for the cortex, right? The primary motor, premotor, and so on. What you need to know in the cerebral strokes is that strokes don't cross because of the homunculus and the distribution that you have of what side controls the lower limbs and what side controls the upper limb. So you would usually in a cerebral stroke, you would mostly have, like loss of one arm or one leg. They don't cross. But for the posterior limb, which has this whole tract passing through it, damage to the posterior limb of the internal capsule would lead to contralateral hemiplegia of the opposite side. So whole body on the opposite side, half of it. The limbs, upper and lower, and it can also lead to contralateral sensory loss because again, those tracts pass through it. It can lead to visual defects of the auditory tract is disturbed or damaged. It can lead to a myriad of really symptoms. The genu, which is a little curvature point, damage here could lead to the contralateral facial weakness. Now remember that the genu contains the cortical bulbar fibers, so these are essentially upper motor neurons for facial nerve endings. And so damage here would lead to an upper motor neuron lesion, which would cause lower facial weakness on the contralateral side and not full facial weakness, because as we remember the face has upper motor neurons and lower motor. The lower motor gives it like two sets. The lower motor neuron is essentially giving supportive senses to both sides and it's supporting everything, while the upper motor neuron lesion would really just have one side. I hope I'm making sense of the terminology I'm using, but essentially there's yeah, sorry. Essentially, there is more support in the lower motor neuron. So if a lower motor neuron was damaged, as you see in Bell's palsy, you would notice full facial weakness on the contralateral side, while for upper motor neuron lesion, you would just see for lower half of it because the lower motor neuron is still making up for it on this side and this side. That's what I'm trying to get aside from this. Then it can also lead to dysarthria because again, these are all the facial nerves controlling the movement. These are all the cranial nerves controlling the movement of the face and the tongue and so on. It can cause tongue deviation away from the lesion, and it can cause uvula deviation towards the lesion. This is straight up memorization. Don't even try to risk it. Know that's like a rule of thumb, so it's easy for your questions. Again, here we're mentioning all the damages that can occur for a posterior limb insult. It can be hemiplegia, you can have anesthesia, which is lack of symptom, lack of senses being processed, contralateral homonymous hemianopia, which is auditory defects. You can also have bilateral hearing loss by the auditory radiation tract, which is retrolentiform. With that, we cover the internal capsule, and we now move on into the cerebellum. The cerebellum is like a tiny brain located under your main brain, and it's usually controlling a lot of your posture, your control, your balance, and whatnot. It's also controlling your movements. Again, as we mentioned for the thalamus and basal ganglia, the cerebellum really helps refine your movements, make sure they're symmetrical, and so on. So the way it works is it works as a comparator, as Dr. Akin likes to explain it. It compares the intended movement with the actual one that's being carried out, like what would want it to be done and what you're doing right now, and it helps correct it if there's errors. Rule of thumb with the cerebellum, it's always, always ipsilateral. Don't play around with it. Don't think too hard on it. Don't think of any tracks. Just know cerebellar defects are always ipsilateral because there's double crossing over of the fibers. Yes, they're crossing over once, and then they're crossing over again. So regardless of how the path looks, a cerebellar lesion would always affect the right side. Oh, sorry, the ipsilateral side. And this is a little image to show you what the cerebellum looks like. It kind of looks like a little walnut, to be honest, but then again, the brain looks like a walnut, so it's like a tiny walnut. Cerebellum has, uh, the cerebellum in general, Dr. Yakin likes to follow a rule of three, which is, it's ironic because this is our third lecture for today. So it has three lobes. You have the cerebellar hemispheres on the side, and then you have the central part, which is cerebellar vermis. Another way it can be referred to is as the anterior lobe, the posterior lobe, and then the flocculonodular lobe, which is also here and here for your reference. Um, then something called like a little anatomy detour before we move on into more important things is something called the cerebellar tonsils, which you notice are right here. As they're sitting, as they're sitting at the very base of the cerebellum, they can very easily herniate. And upon herniating, they can they're not going to just herniate out of nowhere. It's obviously when there's damage being done, but they can herniate and they can essentially affect the brainstem and press on it and so on. That's something to know of the clinical significance of some of the cerebellar anatomy in that case. But moving on to, again, the more important parts. Following the rule of three, we have an anatomical distribution of the lobes, anterior, posterior, flocculonodular, or we have a functional distribution of them, which is vestibulocerebellum, which is essentially the flocculonodular lobe. And as whenever you hear vestibular, you would think of balance, you think of eye movements and how it's coordinated. So that's flocculonodular lobe, the vestibulocerebellum, that function. Then you have the spinocerebellum. Spine, think of the center of your body and so on. So this is in the vermis. It's in the intermediate zone in between. So far, we've done vermis and we've done flocculonodular lobe. Over here, vermis again, spinocerebellar tracts. Think of the center of your body. It's controlling posture and trunk controls in the center. Then you have the cerebrocerebellum, which is on the sides of it. These are the lateral hemispheres, and these are mostly for your voluntary movements of your limbs. So trunk in the center, limbs on the side, as they tend to be in flocculonodular for balance and eye movements. Now for the cerebellum, again, following the rule of three, we have an input and output. In ins, we have two. It has two major inputs, the middle peduncle and the inferior peduncle. These are two inputs for the cerebellum. And you have one major output, which is the superior peduncle. Now, this is just to understand where information is coming into the cerebellum from. So the middle peduncle comes and it brings pontocerebellar fibers from the cortex, and the inferior peduncle brings proprioceptive input. Very important to know because the cerebellum is essentially dealing with balance. Proprioception is what helps you determine your stance in space when your eyes are closed, for example. So proprioceptive input from the spinal cord, to the inferior olivary nucleus, and through the vestibular system. So that's where you're getting your input from. And how are you sending it out? You're sending it out through the superior peduncle, which connects it to the midbrain and the thalamus, and so on. Now there's three layers of the cerebellum: molecular, Purkinje, and granule. So we can come and appreciate them over here. Molecular is the outermost, and granule is the innermost, and Purkinje is in between. So if we start from the granule, we'll see some granule cells coming up, and we see them as they move across the layers, and they come and they're essentially synapsing with cells. They also have something called Golgi cells, which are not highlighted here, but they're part of the granule cell layer. Then we come into the Purkinje layer, which contains obviously the Purkinje cells. It's just one layer, so there's just one cell, like Purkinje cell, like this, one here in each cell. And you can see that it's going to be interacting with a bunch of fibers that are coming in, and we're going to get into them. But essentially, granule cell layer containing the granule cells in the Golgi body, Purkinje cell layer containing the singular Purkinje cell, and then the molecular layer, which contains the dendrites that are coming out of this Purkinje cell and its associations with all the other fibers that are involved. Now, the Purkinje cells are an important part of your output. As we mentioned, we're going to have output through the superior peduncle that is done through the deep nuclei, which receives projections from the Purkinje cells. So the Purkinje cells are sending output to the deep nuclei, which is essentially coordinating everything forward through the superior peduncle. Then we move on into the fibers, as we mentioned. Now, the fibers are essentially just part of the input. The middle and the inferior peduncle are bringing them in, and they're essentially going to be the ones interacting with the cells you see. So let's start off with the mossy fiber over here. The mossy fiber is coming and it's bringing input from the pontine nuclei in the vestibular system, the spinal cord, and here it's going to synapse with the granule cell. The granule cell is then going to give off something called the parallel fiber, which is going to run alongside the molecular layer, and it's going to start interacting with the dendrites of the Purkinje cells. Here it's interacting with one part of it, and as you continue to move along it, you'll have another Purkinje cell, a lot of its dendrites, and it's going to continue to interact with them moving onwards. So one mossy fiber, and therefore its parallel fiber, is interacting with a bunch of Purkinje cells as they move along. Then the Purkinje cells obviously will send projections down to the deep nuclei, which will then inhibit or activate the thalamus. So that the main output that you have is the deep nuclei. Don't forget that. Then we come into the climbing fibers, which are here. They're coming from the inferior olivary. They climb up and they just directly interact with all the dendrites of the Purkinje cell, but they're interacting with only one. So know the difference that the mossy fibers are interacting with multiple Purkinje cells, while the climbing fibers are only interacting with a single Purkinje cell. The obvious output is still the same. It's through the deep nuclei, and it's going to send it forward to the thalamus. The climbing fibers are particularly important for motor learning or movements, essentially. This is again just a summary of the ins and outs of your cerebellum. And again, just to note, the deep nuclei is the main point for your superior peduncle output, and it connects to the midbrain and to the thalamus. And as we've learned the thalamus and all of its little lobes, we know that it's going to go to the VL of the thalamus. Then we're going to cover the nuclei that are involved in the cerebellum. There's a total of three. There's the dentate nucleus, there's the emboliform and globose nucleus, which is also known as the interposed nucleus together. So it's one set. So one, two, and then three, the vestigial nucleus. Here you should appreciate that they're really moving in a medial to lateral direction. Sorry, lateral to medial direction, with the dentate nucleus being the most lateral and the vestigial nucleus being the most medial. This is obviously relevant when it comes to what are they controlling? Are they controlling limbs? Are they controlling your posture? Which, as you know, of the cerebellum overall, you can pretty much figure out that the more lateral ones are controlling your limbs and the more medial ones are for your trunk and so on. So coming to the nuclei that we have, remember that the dentate nucleus is what we mentioned all the way back in the thalamus for the VA-VL circuits, and that the dentate nucleus is the source is the way the cerebellum is essentially communicating with the VA-VL, which is then later on sent to the Brodmann areas, right? VL specifically, not VA. VA is again for basal ganglia. VL is for cerebellum. Be sure to make that distinction. The dentate nucleus on the lateral side mostly is responsible for movements like skilled movements of dexterity, and they again output to the thalamus, as we mentioned. The interposed nuclei, which is made of the emboliform and globus nucleus, are, as you notice here, they're coming more towards the midline, so they're responsible for your posture and your muscle tone, and they communicate through their red nucleus. And they use that to communicate to the midbrain. Very important to note that it's the red nucleus. And then you have the vestigial nucleus, which is the most medial, and they control the trunk mostly and the tone and posture of it, and also your balance. And they're related also to the vestibular nuclei. That would also, again, correlate to your balance. With that, we have covered what the cerebellum has and what its tracts look like, what its fibers are, what are its ins and outs. And now you need to understand what cerebellar disorders can look like, right? So we mentioned that we have a vermis, and then we have a lobe here and a lobe here, and then a flocculonodular lobe here. Obviously, it doesn't look like this, but you get the gist. Damages here would affect your limbs. Damages here would affect your trunk, your central posture, and your balance, and damages here would again affect your balance. So, if it's a hemisphere that's damaged on the two sides, it can lead to limbotaxia. It can lead to dysmetria. Dysmetria is essentially, uh, think of it like lack of coordination, right? So, the finger to nose test, which is you ask the patient to put their finger on their nose and then bring it to touch you, they wouldn't be able to do it. They'll like overshoot or undershoot. There can also be something called an intention tremor, which is what you've seen quite frequently in a lot of cases where essentially what they're doing is as they're trying to make an action, their hands start shaking a lot more. This is different from the tremor that you see in Parkinson's, which is a rest tremor, which goes away when you're carrying out actions. Intention tremor is again where they're overshooting or undershooting as they're trying to make a certain action. Their hands are going to go way too up or way too down. You also have dysdiadochokinesia. This is when you ask them to essentially flap their hands back and forth against their palm, and they're going to be their hands are going to end up not being able to carry out the action well. Again, note that for the cerebellum, the signs are ipsilateral. They're all on one side. Right side of the let's say you're seeing right-sided symptoms. Your lesion is on the right side of the cerebellum, the right hemisphere. Don't overcomplicate it in this part. Then we look at the vermis. The vermis essentially is again what's controlling your trunk and your posture and so on. So damage here would lead to truncal ataxia. It would lead to a wide-based gait as you're trying to stabilize yourself and increase your center of gravity. And it would also cause difficulty in sitting upright because again your posture is no longer being supported by the cerebellum. A flocculonodular lesion over here, remember that it's responsible for the vestibular system. So here it would cause balance problems, nystagmus, postural instability. And in children, you very commonly see this due to a medulloblastoma that's being formed and impinging on it. Some syndromes that are like directly mentioned as well in your lecture are the anterior vermis or cerebellar syndrome. This is again in the center here, but now we're talking anteriorly, so it's more over here. So more over here, it's affecting your lower limbs versus, or like the lower limbs of your body more commonly. And sorry. And more over here, it's affecting your upper limbs. That's just a homunculus distribution. It's not too much of importance to note, but essentially, the anterior part of your vermis is also supporting if you're looking at your trunk and you're looking at it in the sense that the anterior part of the vermis is like trunk and let's say down, while the posterior side of the vermis is trunk and up, right? So the anterior part of the vermis here, it's going to cause like disturbances in your balance, particularly when pertaining to your leg. They're going to cause an unsteady gait, again, wide base because your legs are not able to coordinate well, so you're increasing your stance. You're trying to make it wider so you're more stable. Alongside this, obviously, the more common thing is leg ataxia, but you might also notice trunk ataxia, which is again just postural, which is very common with the vermis. This is very commonly seen in alcoholics. Then you have posterior vermis syndrome, which is seen in children. As you mentioned, it's medulloblastoma. Medulloblastoma, it's compressing on the flocculonodular lobe, which is affecting the vermis as well. And this mostly just gives you truncal ataxia, which is just a classic vermis sign. And these are just some tests for you to refer to for your cerebellum. You can see the finger to nose test. You can see over here, and you can see that they'd be able to miss it. You would also see the dysdiadochokinesia test, which is the alternative rotations against your palm, and then the heel to shin test, which is again just testing a lower limb ataxia, which is something you would see in an anterior vermis syndrome. With that, we have wrapped up the cerebellum. I hope it was clear and I hope it was helpful. And then we move on into the limbic system. The limbic system, as we discussed earlier, is essentially responsible for home. What that means is home refers to the four main functions that are being carried out by the limbic system. Homeostasis via the hypothalamus, olfaction by the olfactory cortex, memory via the hippocampus, and emotions via the amygdala. This little diagram over here is supposed to highlight uh, the overall limbic system for you. You can see it's a series of structures, and it has the hippocampus, it has the dentate gyrus, it has the mammillary bodies. It can also have commissures connecting both parts of it in between, and so on. So, again, for you to know the components that are being formed for the limbic system, you have the hippocampal formation, which is a series of things. You have the fornix, you have the hypothalamus partially, you have the amygdala, as we know, you have the thalamus, as we know, anterior nuclei and dorsomedial nuclei. You can also have the limbic cortex, which involves the gyri over here, and then olfactory structures. We're mostly going to learn the limbic system in relation to the functions it's carrying out. That means home. So hypothalamus, again, it's done. We know it. We know the homeostasis it does. We know the endocrine functions. So home is done. We come into O. So the way this starts is you have olfactory sensors that are obviously picking up like your first order neurons, which are picking up the senses, uh, and they're all the way down in your nose. And from there, they're going to synapse forward and send it forward into something known as the olfactory bulb, which becomes your second order neurons. It's important to note that these are two-poled, and I've tried to represent that through the two little circles that we have here. And from there, they're going to send it forward. The senses that you're getting, remember, they're bypassing the thalamus, and they're going to essentially directly send it into three areas, which are the piriform cortex, the entorhinal cortex, and the amygdala. Three regions that are involved of the limbic system for processing smell. Now, part of it is for the chemical part of it, dealing with the actual smell, what it has, its components, and then part of it is for the emotion associated with it. Obviously, anything emotion related is through the amygdala, and now the more sciencey part of it, if you will, is through the piriform cortex and the entorhinal cortex, which are essentially located in the parahippocampal gyrus, specifically at the layer of the uncus, and this is where they start analyzing the smell. Now, as we mentioned, there's going to be commissures that are connecting both parts of the limbic system on the right and the left side. So, smell is always analyzed bilaterally. So, what that means is a lesion on one side does not necessarily mean that you'll lose your sense of smell. So that covers olfaction. We have an olfactory bulb. We know that it's sending things forward to the piriform cortex, first of all, which is of most importance, then the entorhinal cortex, and then the amygdala. The way this is tested is essentially they'll just ask you, oh, this patient came in not able to smell. Where's the lesion? And it could be the piriform cortex, for example. Okay. Then moving on, we did H, we did O. Now we're going to talk about memory. The memory function of the limbic system, which is a very, very important function, if you will. Now, memory has two parts. There's something called declarative long-term memory and non-declarative long-term memory. Short-term memory, first of all, is just something that you're learning immediately and retaining for short periods of time, versus long-term memory is something that consolidates it further. Now you're going to be able to remember it for a longer duration. So long-term memory essentially is made up of declarative and non-declarative. Declarative involves facts and semantics and experiences. So facts like, oh, okay, I remember that the olfactory, oh, that's not long-term, but I remember, let's say, something that I learned about neuro a little while back, and I still remember and I can quote it for you guys. So that's declarative versus experiences. Oh, I remember that I did this when I was 5 years old. So that's long-term memory. It's consolidation. And I remember this event. So these are things that you can state and you can picture essentially. Non-declarative memory is something that isn't like consciously recalled. It's just something that you're inherently doing. So if it's procedural, it's like knowing how to tie your laces or shooting a basketball or running or walking. These are non-declarative memories to be able to do them. Skeletal can include breathing, like your body remembers how to contract its muscles to breathe. And emotional is primitive responses. So like let's say you were young and you developed a fear of snakes because of an interaction with them. The next time you see a snake, years later, your body will have that non-declarative long-term memory where it's going to see a snake and it's going to have a complete like emotional and psychological reaction to it and it's going to back off. Now, amnesia essentially is when there's damage to the memory consolidation process, and it can either be anterograde or retrograde. Anterograde, as it suggests, is that you're not able to create new memories after a specific event. This is very common in a PCA or artery of perturbation stroke. It can also be common in a temporal lobe lesion or in a medial diencephalic, which is the thalamus lesion. Because again, these are the coordinating bodies for it. Remember, the anterior nucleus of the thalamus is very important for memory. We also remember the PCA and the pertinent arteries support and supply to the thalamus and to the basal ganglia and support their function. So damage is here, but obviously lead to stroke. Retrograde amnesia is you can't remember certain events backwards. Anterograde is you can't make new memories, you can't remember what happened after this certain event that damaged your memory. And retrograde is, okay, certain events happen and you remember nothing from the past event. There are severe cases where both can occur simultaneously, although obviously not that commonly encountered. Okay, so now after we've discussed the major memory functions that are being done, and this is again in the hippocampus specifically, we'll now come into something else related to the hippocampus, which is the hippocampal formation. Now, this is essentially a series of structures, particularly the hippocampus, the dentate gyrus, and the subiculum. Now, these three structures are all part of the allocortex, which essentially means they all have three layers. Just know that. There's three structures that we're mentioning, and they all have three layers. They have something called the molecular layer, the granular layer, or the pyramidal layer, based on what's containing it, and then the polymorphic layer. Now, the hippocampus and the subiculum both contain pyramidal cells in the middle layer, while the dentate gyrus only contains granule cells in the middle layer. That's where they differentiate. Another reason where they differentiate is that the hippocampus and subiculum are both excitatory in their action, while the dentate gyrus is inhibitory. So, what the hell do we mean by excitatory and inhibitory? As you recall, excitatory means that they're going to be sending out glutamate, while inhibitory means they're going to be sending out GABA, like we saw previously in the basal ganglia and that circuit. That's what excitatory and inhibitory would always refer to, and that's a good way to remember it. Now, as you mentioned, these three are part of the allocortex, three layers only. Another thing to note is the parahippocampal gyrus, which is not part of this, which is a neocortex. So it has six layers. So this can be a very simple comparison question that could be asked of you. Is the dentate gyrus of three layers, of six layers, of five layers? So it's good to know that it's of three layers, and so on. Now, where does this come in? This comes into the hippocampal circuitry. And these are, again, as remember, the main function of the hippocampus in the sense is memory consolidation. These are just circuits to help demonstrate how they work. We have two main pathways. We have the perforant and the alveolar and the alvear, sorry. So as the name suggests, the perforant is perforating through something. So this is your starting point in the intrarenal cortex, which is part of the parahippocampal gyrus, and it's going to be sending out synapses all the way over here, and it's going to perforate through the sulcus, separating them, moving from the subiculum into the dentate gyrus, and moving from the subiculum, which is, as we recall, excitatory, to the dentate gyrus, we're sending out glutamate. And now the dentate gyrus is responsible for sending the signal forward, and because the dentate gyrus, as we recall, is inhibitory, it's going to send GABA along to then synapse all the way over here in CA3. Now, obviously, these labeling, CA1, CA2, CA3, CA4, these are just to label the different parts of the hippocampal formation. What you need to understand is essentially the difference between the perforant and alvear, sorry, in terms of signaling and how it's going on. The perforant is showing that it's a very, like, indirect type of route, really. You're going all the way forward and then it's sending it back. So the dentate gyrus is sending out inhibitory signals to all the way over here in CA3, which then synapses again at CA1. Now, here, what you have from the dentate gyrus is something coming out called mossy fibers, not the cerebellar kind. These are mossy fibers sending out inhibitory signals, while all these green ones over here are called Schoeffer excuse my spelling of a Schoffer fibers instead, and these are going to be sending out the excitatory fibers. This is just to show hippocampal circuitry. It's not of utmost importance to know what's where and what's who, but just to understand really how are they functioning. The dentate gyrus functions inhibitory, subiculum and CA3 and CA4 and CA2. So subiculum, sorry, subiculum, CA3, CA2, CA1 are functioning more on the stimulatory side through glutamate. And then you have the alveolar side. So on the alveolar side, what you're noticing is there's no perforation occurring through the gyrus that's separating the subiculum and the dentate gyrus, the sulcus, sorry. So what you have essentially is signals being sent from the intrarenal cortex to the CA1, CA3, CA2, and back to CA1, and these are through the Schaffer fibers. And now, again, note that this contains only the pyramidal cells, which are communicating through glutamate release, as opposed to the perforant side, which is communicating through GABA release in the mossy fibers, and this mostly contains granule cells. Again, I know it can seem confusing, it always is, but just what you need to understand from the hippocampus and its three little parts in the hippocampal formation are how they're communicating. Dentate gyrus is inhibitory, subiculum is excitatory, hippocampus is excitatory. And perforant pathways, you notice that's the only one involving the dentate gyrus, and it's really causing signals to bypass and move all the way into the subiculum, and from the subiculum into the dentate gyrus across the sulcus, while in the alveolar, you're not even going near the dentate gyrus and you're just, coming back in. Either way, the most important point in both of these are the subiculum. It's the most common one. It's the one that's being used regardless of perforant or alveolar. So the subiculum is a very important part of hippocampal circuitry. Now, as we come into another part of the hippocampus and its functions, we're going to come into something called long-term potentiation, which essentially is just the process of neuroplasticity and forming new synapses and learning and whatnot. Now, coming back here, as we know, the CA1 and the subiculum, these are very important parts of the hippocampal circuitry. So they're very important in long-term potentiation, and they're very easily susceptible to anoxia, which is lack of oxygen. Slight loss here would lead to major damages down the line. Something that's involved in long-term potentiation are a bunch of receptors: AMPA receptor, NMDA receptor, and calcium. Now, this can be a bit hefty in information, so I'm mostly just going to cover what's important of it. These receptors are working overall to send signals forward, as we've seen here, and AMPA receptors are essentially for excitatory synaptic transmission, right? Excitatory. So that means they're going to be using glutamate, they're going to be using it to open channels, send ions forward, and whatnot. So what is the AMPA receptor doing? It's the excitatory one. It's responsible for activation of these synapses, essentially. Then you have something called the NMDA receptor, which is usually blocked by magnesium. And when depolarization occurs, and that's through the entrance of ions like sodium into the neuron, this block by magnesium is removed. So this channel opens, NMDA receptor opens, and it allows calcium to enter into your neuron, essentially. And once calcium enters, it causes protein, it activates protein kinases, it allows transcription to occur, it causes synaptic remodeling. And what does this lead to? It leads to increased AMPA receptors again. So we're back here and we're going to have more excitatory synaptic transmissions. So more activation of synapses in that initial phase. So more synapses being formed. So what we need to understand is AMPA receptors are responsible for the actual synaptic connections being formed. And you need to, overall, what you want to do is you want to increase it for long-term potentiation, long-term memory storage. How do you do that? It's directly increased by calcium, which an influx of calcium into the cells allows for these receptors to increase and allow more connections to be formed. It's indirectly increased by the NMDA receptor, which when it opens up, it allows calcium to enter into the neuron. I hope that was clear. And inshallah, we'll move on into the next part then. This is again just a little recap of the anterior nucleus, as we mentioned, the PAPA circuit, which is part of the limbic system that's responsible for memory consolidation using the anterior nuclei. Damage can cause amnesia, as we've discussed multiple times. Another important transmitter that you need to know for the PAPA circuit, alongside everything else we've learned, is acetylcholine. This one comes from the basal nucleus of Maynard, and it again just supports the functions more. So when you have Alzheimer's, which is essentially a memory loss dementia disease, you would have the basal nucleus of Maynard damaged, meaning there's less acetylcholine coming in and supporting the PAPA circuit. With that, we take a little detour into Alzheimer's. What you need to know about Alzheimer's in relevance to these lectures is that in the cases that it's hereditary, it can be autosomal dominant. In Alzheimer's, what you're having is irregular proteins and irregular tangles being deposited onto the body. So you have amyloid beta proteins being deposited, and they're coming from amyloid precursor proteins. And you also have abnormal tau proteins being deposited on the brain, and these can lead to neurofibrillary tangles as they associate with all the surrounding cells, of the glial cells and the astrocytes, and they're causing tangles. And essentially, they're just deposits being formed on the Alzheimer's and on the brain in Alzheimer's. These deposits can damage the basal nucleus of Maynard, or there can just be a general loss, a gradual loss of this nucleus of Maynard. And with this, you have less ACH being produced, and this can lead to dementia because, again, your memory consolidating circuit, which is the PAPA circuit, which involves a neurotransmitter acetylcholine, does not have it anymore. So memory is no longer being processed the way it should be. There are some trophic factors like nerve growth factor, which are being researched, which can slow down the which can slow down the degradation, apologies, of the ACH producing cells. Then the last one we come into is emotion. As we know, emotion is carried out by the amygdala, and it's supplied by the anterior choroidal artery. With that, we cover what are the functions of the limbic system, so let's recap them. We have homeostasis done by the hypothalamus. We have olfaction done through the olfactory system. We have memory consolidation done through the hippocampus and the hippocampal formation and all its little circuits, perforant and alveolar. And then we have emotion, which is managed by the amygdala. This is the last slide as per the teaching part. Let's just lock in some limbic system disorders that you might know are Clever-Bucy or Wernicke-Korsakoff. We start with Clever-Bucy, or however you want to pronounce it. This is a lesion that affects the amygdala. So you can imagine what that means. This is the part that's controlling all the emotional aspects of your brain. So a lesion here would lead to a placid effect, which means no emotions are noticed, whether it be fear or sadness or anything like that. So this is referred to as a placid effect. And it can be hypersexuality, which is experiencing like high sexual desire for no reason. And you can also have oral exploratory behavior, which is they put everything in their mouth. So these are a lot of inappropriate behaviors, and they're essentially caused by the amygdala not functioning the way it's supposed to. So your emotional regulation is pretty much gone. This is something that can occur because of a herpes simplex virus type 1 complication, and that's important to note because these can very easily lead to meningitis and encephalitis in their complications. And then we talk about, and in these meningitis and encephalitis, they specifically target the limbic system. Moving on, Wernicke and Korsakoff syndrome, they're both the same syndrome. This one is acute and one is chronic. Wernicke's is acute and Korsakoff is chronic. Oh, sorry for the line there. And they occur because of chronic alcoholism. So Wernicke's encephalopathy, as you mentioned, is acute and Korsakoff is chronic. And in Wernicke's, you have some mental changes. Your dorsal medial nucleus is being affected, which is again related to the emotional part of things. So you're having behavioral changes and mental changes. You can also have abnormal eye movements, and you can also have gait ataxia. So you're really affecting all these areas. And then in Korsakoff syndrome, which is a more chronic state that occurs from alcoholism, you can have more permanent losses. You can have psychosis. You can have anterograde memory loss. And you can also end up having confabulations, which is where you end up making things up because you can't remember events. And Korsakoff syndrome, essentially what you're having is degeneration of mammillary neurons. Again, mammillary neurons are a very important part of the of the PAPA circuit, if you will, and that's where memory consolidation is going down the drain. The problem that's occurring here is essentially the chronic alcoholism is causing B1 or thiamine deficiency, and that's affecting negatively the Wernicke's area and Wernicke's area and the mammillary bodies. So the treatment for them is usually with B1, and that would really help, I guess, taper a lot of the symptoms that you experience in this syndrome. With that, we come to an end with the actual teaching part. So now I'm just going to bring a bunch of questions for you guys to read. I won't be reading them because they are quite long, but I want you to obviously pay attention to them. You can pause the video, and then whenever you're ready to answer, you can go ahead and do that. So in this case, what we're looking at is a right cerebellar lesion. Obviously, please make the distinction already that this is going to be causing symptoms on the right side. Now, when we have a cerebellar lesion like this and it's on the hemisphere, this is very easily causing an abnormal finger-to-nose test. Upbeat nystagmus wouldn't be really caused by a cerebellar hemisphere lesion. Nystagmus could be seen with a flocculonodular lesion. Yes. Truncal ataxia is again more on the vermis side. Arresting tremor is really not seen. In this case, arresting tremor is part of Parkinson's. It's not related to this. And a positive Romberg sign, a distinction I wanted to make for you guys, is that this positive Romberg essentially is when you have them close their eyes and see if they can maintain their balance, which is essentially you're testing their proprioceptive capabilities. So Romberg test mostly just determines whether the person is having ataxia because of sensory losses or not. It doesn't really narrow it down to the cerebellum, if that makes sense. In this case, in this sense, you're going to be having a normal finger to nose test because that is the one that's relevant to the hemispheres. Moving on to the next case that we have. Again, you can pause and answer whenever you're ready. This is a patient who had hypertension, and then later they showed that he has decreased sensation to pinprick and temperature. And yeah, you can see that right over here. And his motor strength is fine. His deep tender reflexes are also fine. They're asking, he's just losing a lot of sensation on one side. So really, what is it that's causing his symptoms? So really read over these and think about it. And the answer is ventral posterior thalamus, which is responsible for all the somatosensory and sensory input that you were getting. Remember the VPL and the VPM. This one here specifically would be the VPL and not the VPM, which is more for the face. And yeah. That's this question. Parietal lobe, you wouldn't really have something that big showing this type of sign. And posterior limb of the internal capsule would mostly give you like hemiplegia on the whole right side, and it would also bring a whole lot of other symptoms like motor loss, hemiplegia, and so on. Lateral medulla is responsible for this type of symptoms. Neither is the basal pons, and neither is the subthalamic nuclei. That is way too specific of an answer. So we have the ventral posterior thalamus. Moving on to the next question. She has pain, nausea. She can't sit upright. She needs to prop herself on her hands. She is showing nystagmus, neck stiffness, head tilting, broad-based gait. She can't perform a balance test. So now we're trying to figure out where is she having this lesion. So is it in the posterior spinal cord? Is it in the pyramidal tracts? Is it in the cerebellar vermis? Is it in the flocculonodular lobe, the frontal lobe, or cerebellar hemisphere? The answer is pretty obvious. It's in the cerebellar vermis because this is a more truncal set of symptoms that you're having. She's not really able to maintain her posture, whether sitting or not. And this is a very important and distinctive sign. With that, we come to the end of this pal. Well, I wrote a nice text for you guys, but I guess it got blocked. But essentially, again, Ramadan Mubarak to you guys. I hope the rest of your Ramadan and the rest of your vacation leading up to New Year goes really well. May Allah add immense barakah to everything that you do, and I wish you all the very best for your exam. I truly hope that this pal was of help to you guys. If you have any questions, any concerns, feel free to reach out at any point. There's a little QR code if you have any feedback to submit. And yeah, with that, I'll let you guys go. Assalamu alaikum and all the very best.